This program is brought to you by Emory University.
Yeah. Good morning. It's a pleasure to introduce our speaker for this morning, Dr. Andrea Russo. Dr. Russo is a professor of medicine at Cooper Medical School. She's the director of the EP and the fellowship director. Prior to joining Cooper, Dr. Russo was a faculty at Penn from 1997 to 2008, where she was the director of EP at Penn Presbyterian Hospital. Dr. Russo is the president-elect of the Heart Rhythm Society. She's also a member of the board of trustees of the Heart Rhythm Society. She's chaired or co-chaired multiple writing group consensus document for the American College of Cardiology and American Heart Association. Dr. Russo has authored many papers, and she has special interest in devices, specifically the subcutaneous ICD, and also one of her interests is atrial fibrillation, and she'll be discussing this important topic this morning. Thank you.
Thank you. Thank you for inviting me. It's really a pleasure to be here and to see your lovely campus and just an incredible program at your center. So I'm going to talk about what we call subclinical atrial fibrillation. It's a term that was coined, and I'll define it for you, but it's detected by implanted devices. And the question is always, should we be anticoagulating these patients? And here are my disclosures. So I'm going to start out by a case, and I know this is not an audience response system, but I may just ask for a show of hands, just out of curiosity. A 64-year-old male with a history of hypertension who has a non-ischemic cardiomyopathy and a little bit of heart failure initially, syncope, sustained VT, and has a dual-chamber ICD implanted for that. Had a normal coronary arteries, a cath, and has an ejection fraction initially of 30%. A follow-up echo was done, and EF didn't improve that much, but a little bit better, is on reasonable heart failure drugs, normal labs, and has a routine remote interrogation. So in the EP world, we see a lot of this, or our nurses and PAs and NPs see a lot of this. A lot of information comes across related to arrhythmias you may never have seen before. And in this case, there was atrial fibrillation, and it represented 0.2% of the time since the last interrogation, and the longest episode was 45 minutes long, but there were two shorter episodes, and then sometimes you see this little baseline noise, which is just nothing, it's like over-sensing most of the time, but you could see here was the longer episode. And then nicely, you can actually look at the intracardiac electrograms to see what's going on, and this is the longer episode, 45 minutes. You see the atrial rates are as high as 400 beats a minute. Also consistent with atrial fibrillation. You just want to make sure it's not noise or something on there. And you can look at the electrogram, and you can see it's like a fib, flutter kind of rhythm. So now the patient has no symptoms, no palpitations, no lightheadedness, chest pain, shortness of breath, never had any documentation by ECG of atrial fibrillation. So unless this patient had a device in, you wouldn't even know about this. So what would you recommend in this patient? So longest episode, 45 minutes. Would you prescribe aspirin, clopidogrel? Would you put them on some anticoagulant such as apixaban? Not do anything, or consider enrolling them in a trial if you have something at your center to do that. And just by a show of hands, and there's really no right answer here, I could just tell you that, so don't feel badly if you don't know the answer, because I don't know the answer, but who would put them on an anticoagulant? And so I think that's a good, it's probably half of the room or more than half of the room. And how many people would add aspirin? No, I have no takers there, and and then in either additional therapy or trial enrollment, it would be another issue. But I would have answered an anticoagulant too until we had a trial that we could enroll these patients in, because I didn't know what to do either. But let me just show you another scenario, same patient, except this is the interrogation this time. So now you're up to 1.9% AFib burden, and now you see like you're getting this little cluster of AFib. But the longest episode here is 7 hours. How many people would anticoagulate that patient? So more hands. Okay. And I would have said the same thing too, but I'm going to show you some of the data that says that we don't really have data to do that per se, but hopefully we'll have some in the near future. So atrial fibrillation, as everyone in this room knows, because we get a lot more and more patients, and especially the EP group, I'm sure, sees lots of new consults for atrial fibrillation. The prevalence across the world, and this was back in 2010, was estimated to be over 33 million, so a lot more than that now. But you can see North America is red, and that means there's a lot of AFib. We have the Asian countries here that have a much lower prevalence of atrial fibrillation. And it's projected, depending on what study you look at, and depending on whether or not we continue to have an increased incidence of atrial fibrillation, by 2050, we have over 3 million people now, but by 2050, we may have 12 million or more patients with atrial fibrillation. So this is really an epidemic. And we have to figure out how to treat it and how to treat large numbers of patients with this arrhythmia. Now, obviously, stroke is the one thing we worry about, and we're going to kind of focus on that part of it as opposed to, rhythm and rate control and all those other things. But AFib is a preventable cause of recurrent stroke for sure, and about 1/3 of all strokes are thought to be due to atrial fibrillation. And these strokes in people with AFib tend to be more severe than non-AF strokes. It's common to diagnose this when it's asymptomatic. And we even have, and you may not diagnose it until after you have your stroke, and we call this term that was coined subclinical AFib. And the way that was defined is that you have asymptomatic, short-lasting episodes detected only with long-term continuous monitoring of some sort and not captured on a routine EKG. So it hasn't been long enough that you had the chance they came to the office. I mean, if you only have 45 minutes of AFib, the chance that they come to your office visit and have AFib would be pretty unlikely, but you're never captured on an EKG. You just see it on some device, and they don't have symptoms. So and this is still looking at clinical atrial fibrillation. Those are the patients that we know have it diagnosed clinically. They have it on EKG. But what do our guidelines say about that? And didn't until the most recent guidelines that were just published last week say anything about the subclinical patients. But if you have, we know the old CHADS-2 score, and I'm showing you that only because a lot of the older literature uses CHADS-2 score. Your risk factors for thromboembolic complications are heart failure, congestive heart failure, hypertension. Age was only one cutoff there. You got 1 point for 75, diabetes and stroke. And then you had a stroke risk. If you had a 2, your risk was pretty high, 4% per year. Then the newer scoring system tried to better differentiate those lower risk patients. So added some other things like vascular disease, age, 1 point for 65 to 74, but 2 points if you're 75 or more now. Female sex was added in there, and the vascular disease. But so you can get a total of 9 points max. And now if you have a CHADS-VASc score of 2, that's a 2% risk per year of stroke, and it's like 1.3 if you're a CHADS-VASc of 1. So these are the guidelines just published again, and it's a focused update of the 2014 guidelines that now lists some new things, a little bit different. Now it looks at AFib with a CHADS-VASc score of 2 or greater in men, or 3 and greater than in women. So it kind of takes away some of the weight of being female in risk in the lower number groups, right, in the lower CHADS-VASc score groups. But recommends anticoagulation in those patients, and it includes all the drugs. Now they just added adoxaban, and that's a class 1 recommendation, and some of that, some high level of evidence. Warfarin, obviously, we had the most studies with that years ago. Now it also adds, what's different is adds NOACs. The NOACs are recommended over warfarin if they're eligible for the NOAC. So that means, except in the situation of moderate to severe mitral stenosis or a mechanical valve, those patients get warfarin. And then for patients with AF and a CHADS-VASc score of 0 in men or 1 in women, it's reasonable to omit anticoagulation. So that's not that much different. Some people used to think aspirin. No one here raised their hand for aspirin in that patient because it doesn't do anything really except to increase the risk of bleeding. So they took that aspirin out. And for patients who have AFib and a CHADS-VASc score of 1 in men or 2 in women, prescribing an oral anticoagulant to reduce thromboembolic stroke may be considered, but that gets a 2B. And in the past, that was, it was really wishy-washy. It said you can give aspirin, you can give an anticoagulant, or you can give nothing. So it just said you might consider it. It just sounds less, not any different data, just sounds less wishy-washy. Now, one thing to remember, too, when you're considering anticoagulation is that every 1 point, and that's just one, risk scoring system is the CHADS-VASc score. There's other ones, but that was a simple one and seemed to serve the purpose most of the time. So the guideline committee, thought that that was still a reasonable one to stick with. But if you look at the points, like vascular disease, this is the risk of stroke in a multivariate analysis in patients who are not on anticoagulation. So what and how much, what's the hazard ratio? You get this is the hazard ratio for hypertension, vascular disease, diabetes. They're all, about one or so. When you look at stroke, it's 2.8, again, but you get 2 points for that. When you look at female sex, it's a 1. You get 1 point for that. If you have a 65 to 74, you're only getting 1 point, but the hazard ratio is much more impressive. And what I'm going to try to impress is that age is, a higher risk factor than a 1 point for having vascular disease. And 75 or more, you do get 2 points. So not all 1 point risk factors are equal. And then before I start talking about the subclinical AFib, just thinking of CHADS-VASc score, that's just one risk system, right? One risk model. But there are other factors, and some other, scorings, include some of these. But you have clinical factors such as impaired renal function. There's a scoring called Atria risk scoring that includes renal dysfunction, either less than a GFR less than 45. Some studies looked at less than 60. That increases your risk of thromboembolic complications in the setting of AFib. Of course, if they're on dialysis, the nephrologists never like us to anticoagulate anyway, but we do know they're at increased risk. Obstructive sleep apnea not only increases your chance of AFib, is a factor that could be associated with an increased risk of thromboembolic complications in the setting of AFib. Hypertrophic cardiomyopathy, even without other risk factors, those patients should get anticoagulated. And then AFib burden, we're going to talk more about because that's an important one. Echo parameters, left atrial volume, size, presence of smoke, also increases the risk of thromboembolic complications. And then other imaging, not that I'm saying you should perform these in your patients, but just to keep in mind, there's other factors that we don't include in CHADS-VASc score, such as atrial fibrosis. All that green stuff is, fibrosis on an MRI scan. And then even this morphology of the appendage, when you have something like this cauliflower appearance, you're higher risk than if you have this chicken wing appearance. I don't know, you can imagine little clots getting caught in there, I guess. And then you have these biomarkers. Again, there's one scoring system called AVC that includes some of the biomarkers, but there's a lot more research to be done in this area to try to decide who to anticoagulate. So if you have a borderline patient, sometimes I'll look at some of these other things and think, well, maybe I should anticoagulate, but just something to keep in mind. Now going to, and this is the last one I'm going to show you on the clinical AFib. So what about AFib burden? It pertains to our patient, even though that's subclinical AFib. So if you look at thromboembolic event rates in those who are not on anticoagulation, and you look at how much AFib burden they have, they divide it up into tertiles. So this is 1, 2, and 3. So 1 is 0.01% to 2.03%. And even that second patient case I showed you was still less than 2%, slightly less, was 1.9%. They have a risk that's here, and then the other ones are shown here. But you could see when you get up to a 3, when you have 11% to 100% AFib, your risk really goes up. But when you're down here, it's less than 1% risk per year of stroke or thromboembolic complications. And that holds true even when you adjust for other factors in the CHADS-VASc score. So AFib burden is important, separate from these other risk factors. And then that Atria score is the one that included the renal dysfunction. It also holds true for that. So that might have some meat to it. So now we'll go over to talk about silent AFib now that you have the anticoagulation background. How do we even find this stuff, right? Well, sometimes you're doing a monitor for a reason because they have symptoms, but we might pick it up on some kind of monitoring. Maybe you're looking for something else, or they had, a stroke and you're looking for, for AFib maybe in those patients, a patch monitor, Holters, ECGs, mobile telemetry, event monitors, where you can record at home and see what they're having. And implantable loop recorders, that we have that available in 3 of the companies. I think the 4th one's coming out soon if it's not already available, where you can inject this little monitor underneath the skin and it'll record your any irregular rhythms, or, they all work a little differently, but you can maybe detect, silent AFib. And then we have devices, and I'm going to focus on these implantable devices, either pacemakers or ICDs, as well as mention something about the loop recorders and what that data might mean in the setting of subclinical AFib. So if you just look at patients who've never had a clinical history of AFib and they undergo a pacemaker implant or a defibrillator implant, and you have this atrial lead that's just sitting there, how often do you find AFib? Well, it's pretty common. You're getting your pacemaker device implanted for a variety of reasons, often sick sinus syndrome, heart block, or you have an indication for an ICD and you put a dual chamber ICD in. And you can have between 10 to 68% of the time, you may pick up atrial fibrillation that you never knew about, and they have no symptoms even in many cases. And it depends on, again, how you define AFib, how long it is, 5 minutes, 6 minutes. This study said 3 beats, so 3 beats they were counting. And then how long you follow them. Obviously, if you follow them 10 years, you'll be more likely to see something than if you follow them, 10 months. And then what's the association? So if you see one of these things, does everyone always have clinical AFib? Well, the answer is no, but it's a much increased risk of that. So if you have this, it's a 5.7-fold increased risk of subsequently developing clinical AFib. And they looked at a meta-analysis of these studies and showed that, when you looked at them all together, subclinical AFib does predict, the development of AFib down the line. Doesn't mean you will. And the risk of developing clinical AFib is much lower, though, than if you already have AFib. Obviously, you don't. So it doesn't mean the stroke risk is lower than if you have clinical AFib. And I'll show you some data on that. So this was one study. Jeff Healy is a researcher up in Canada who's published some really great things. Who's looking at the risk of ischemic stroke or systemic embolism in this setting of subclinical AFib. So this study is often cited. It's called ASSERT, and he took high-risk patients. So if you're going to look, you have to obviously have a large enough group that's going to have AFib. So he took people who were 65 or older and a history of hypertension, and they had to have minimum of those 2 risk factors. And they had a recent device implanted, and he looked at over 6 minutes, you had to have to be diagnosed with subclinical AFib. The rates in the atrium had to be over 190, so it's not just a little atrial tachycardia. And they monitored them for 3 months and followed them for 2.5 years. And he found that subclinical AFib was noted in 10% of these patients. Now, in the patients that had subclinical AFib, this is your risk of stroke. And if you didn't, this is what your risk of stroke. Now, remember, this is blown up. So this is, I love when they do that, right? So here is 100%, but this is blown up. So you can see they are different. It is statistically different, but, this is the difference between the groups. So if you just take those patients who had a CHA2DS2-VASc score of 2, and you just looked at that population within the study, the risk, if you had subclinical AFib, was 1.29% per year. And if you didn't, it was 0.7% per year. So then take you back to your CHA2DS2-VASc score just on your clinical AFib. For clinical AFib, if you have a CHA2DS2-VASc score of 1, the risk of stroke is 1.3% per year. So I don't know how many people, and it depends on how you feel for your patients, but which side you go to. I know a lot of people who don't anticoagulate anyone with CHA2DS2-VASc of 1, and some people anticoagulate everyone. A lot of people are in the middle. So if you anticoagulate all your ones, you may say, I'm going to anticoagulate these people, but the data and the guidelines would say you don't have to anticoagulate. Now it's a little stronger, gives you, you can consider it as a 2B recommendation, but it's not really a must at this point. So, and then not only that, so that's just the presence or absence, but the really important point, and the reason I showed you the burden of AFib that holds for clinical AFib also, in subclinical AFib, what about the duration of those episodes? Is 6 minutes the same as 24 hours or 3 days or 5 days? And the answer is no. So in this group of patients, in the same study, when you divide them up into those that had subclinical AFib that lasted over 24 hours, those patients had an increased risk of thromboembolic complications. However, anything less than that, including having no subclinical AFib here in black, there was no increased risk. So clearly burden of AFib is important. And so what should we do if you're less than 24 hours is the way the question is posed. Because the risk of stroke is no different if it's less than 24 hours, at least in this study. And again, it's a post hoc analysis and, all those, limitations there. Now, to make it even more complicated is, and this is, kind of a weird concept, I think, still, but is when you have your stroke. So these are patients that had devices in place. And there were over 2,400 patients that had devices. And this study looked at the risk of stroke, or stroke occurred in 1.6% of patients who had a stroke. And if you look at the people who had a stroke, only half of those had AFib on their device that they didn't know about within or prior to the episode. The red line is stroke. So this one had it, but it was way before, and only 45% of those actually had it within 30 days prior to the stroke. So if you're thinking the AFib is causing the stroke, like why isn't it occurring sometime close to it? And so, there's all this, theory behind that. Now, either they're having a stroke for another reason, and this study didn't, delve into that in a lot of detail, which is possible, certainly. But that, some people have said it's not the AFib itself, it's what it does to the atrium and increases thrombogenic potential in some patients that is more of a risk marker for stroke as opposed to having AFib and then, causing a clot and then causing stroke. So, from the appendage. So, there's, and we know that about 90% of strokes from AFib are from the left atrial appendage, but there are some that might be outside the appendage. So just to make it more complicated. So, I guess up until, we had the availability of a clinical trial and named Artesia, I'll show you on the next slide. I would also put them on anticoagulation because I didn't know what to do. But there's no, clopidogrel, I guess, is probably a wrong answer. That doesn't really, it wouldn't be aspirin, probably doesn't do anything. But, you make yourself feel better and you feel like the patient's taking something. But, either no additional therapy or trial enrollment could be a right answer here, certainly, because we don't have the data to support those really brief episodes and very low burden of AFib to anticoagulate. Now, if it's over 24 hours, we anticoagulate. And this is, one trial. This is, a multinational trial in Canada, US, and Europe, but it's a double-blind randomized controlled trial looking at, and they have apixaban, I assume, because it's sponsored by apixaban, or I assume that's why. Partially, actually, it's at a research center. Versus, actually, they did aspirin or placebo, because I think they thought up until the last guidelines, in particular, aspirin was in the guidelines. So even though it really doesn't do anything, people felt that they might be giving them something. So you can randomize in a one-to-one fashion to either apixaban or aspirin in those who have less than 24 hours of AFib. That's subclinical, no symptoms, never had an EKG of AFib. But these are high-risk patients. So they have to have at least 6 minutes of AFib in less than 24 hours. But they either had a prior stroke, they have to be 75 or more, or our patient actually was 64, so we'd have to wait until the birthday. But if they're 65 to 74, they have to have at least 2 other risk factors. So these are high-risk patients. To really try to detect a benefit of anticoagulation, you need to have the highest risk. Now, switching gear a little bit, so those are pacemakers and ICDs in those studies. Now, we have these implantable loops that are put in for a variety of reasons, and sometimes, we'll put them in for one reason, and then we'll find AFib. We might put it in for syncope, and then we find AFib, and what do you do with that, too? So, but this is a population of cryptogenic stroke, and in our center, and I think you guys put in a lot of loops for this indication, too. Our neurologists are right on board with this. In fact, they'll consult us for a loop. If they have a stroke, they've done an evaluation. We have a big stroke center. We don't know what to do with these people. We put in a loop monitor. But this was a study comparing that to Holter monitors. And sure enough, as you might expect, you're monitoring for a longer period of time. You're more likely to detect AFib with these implantable loop recorders in this population of patients than if you just do your routine care. And then this was just a meta-analysis looking at, it combined the randomized trials, there were 3, of loop monitors versus wearable devices of some sorts, and the 13 of observational studies. This is just the randomized trials, these 3. And overall, again, you could see better than just doing a mobile telemetry where you could record for 30 days. Again, you're recording longer. Now, if you recorded 2 years later, was that the cause of stroke? I don't know, but we often would anticoagulate that patient, I think. But you were more likely to pick it up the longer you monitor. And this is in that cryptogenic stroke population. Now, the European guidelines from a couple of years ago, took this data and said we're going to include it in our guidelines. If patients have had a TIA or ischemic stroke, they recommend screening with a short-term EKG or some kind of continuous monitoring for at least 72 hours. So, that seems pretty reasonable. That's a class 1 recommendation. And in those who have had a stroke, and they said also you might consider longer-term non-invasive monitoring, 30 days or more, or an implantable loop. So, I think with guidelines, you have to look at how much data is out there, and with the way guideline committees, work. For those in the room participated, you know how that works. But you have to vote. So everyone in that group you have to have an 80% consensus on the recommendation. Otherwise, it doesn't get in. So then what you usually do, you modify it, and then you re-vote, and until you get 80%. And so, it seems like, this got, a 2A recommendation, and you kind of, put it into wording, and you put it into what level of recommendation. I mean, there's some, if you have a lot of randomized trials, it's easy. If they're randomized multi-center trials, that's easy for higher levels of recommendation. If it's lower than that, you may just have some studies, but not a huge number. And then, so our guidelines that came out last week, it's a focused update, included, this is the first time that we included device detection, and I wasn't on this document, but they included device detection of AF and A-Flutter. And the way this is worded, in patients with an implanted device, like a pacemaker or an ICD, the presence of atrial high rate episodes, so those things that are recorded, and you set that in the program where you could say, record something greater than 190 beats a minute in the atrium, and tell me how often that's happening. There's certain out-of-box settings with different devices. But if it's over 190, chances are you might have flutter or fib, so we usually record somewhere in that rate range. Again, this is a soft recommendation here, but it's a high level of recommendation, but what it says is it would prompt further evaluation to document clinically relevant AF to guide treatment decisions. Again, recognizing we don't have data to say anticoagulate these people, and I guess they weren't even willing to say anticoagulate if it's greater than 24 hours. I mean, I think the data is reasonable. Again, it's not a lot of multi-center randomized trials showing that, but the post-hoc data I think looks pretty good for over 24 hours, but it must not have been strong enough for the group to agree. And then in patients who have cryptogenic stroke, though, a different subset, not just those people just walking around with pacemakers or ICDs. These people have strokes that in whom external ambulatory monitoring is inconclusive, which makes me think, again, not being on that writing group, there was some controversy, that implantation of a cardiac loop recorder is reasonable to optimize detection of silent AFib. So they weren't willing to say, the way I read this, do it up front in every cryptogenic stroke, and we are doing that up front in our center, but that it's reasonable to do some external monitoring of these patients first. And so what we did is so since we are doing this, and we did have some controversy among our electrophysiologists as to should we be putting in all these loops. I think 2 out of 3 thought yes, we should be doing everyone, and then one person's like, well, why can't I do monitoring for a little bit? And so what we did, thought it was a great fellow project, is to actually not change our standard of care, what we're doing in our stroke center there, but we took just 20, and he just presented this at AHA. This year, or last year now, the first 27 patients with cryptogenic stroke who received an ILR, we just put on a monitor. And in this case, it was sponsored by the company that, Gus Barty has this company called Barty Diagnostics. And so this is the patch monitor that they have. And the reason we chose that was because you could see P waves really well, and as opposed to some of the companies, with the remote monitoring, and especially some of the patches, you may not be able to see the atrial activity very well. But anyway, so, and we compared that. In this case, they were all Medtronic. We didn't have the other, we have one other device. We have the Avid device now too, but we didn't have it on our purchasing agreement. So we compared those two after the fact. So everyone got a loop recorder, and then we offered patients participation and consecutively, and pretty much most patients who were able to consent, did consent. And we were able to see, this is on the Barty diagnostic monitor, AFib, and it kind of almost looks like a surface lead EKG. Here's the implantable loop recorder diagnosing AFib. They're not simultaneous. It's unlikely that they'll, this is just what the company gives you back. We didn't say a certain time because we didn't know what the other monitor would show, but basically they're in the same patient around the same time. And then this here is, again, the comparison. This one's Flutter. Flutter, by the way, holds the same risk of stroke as fib, so those people should be anticoagulated if you're going to anticoagulate someone. And that this is what the other monitor looks like, from the implantable monitor. And so we found that and they were just 4 weeks, so this patch is not mobile telemetry. It's just a patch, and then you take it off, then you download it, and you get it within, often hours, get the results. You put on another patch, and then, so it was consecutive 4-week monitoring. And we found that in just about 15% of patients in this group had AFib documented in the first 4 weeks, which I was a little surprised it was that early, that it was that high percentage, but that's what it was. And it was the same. So we didn't miss any on either of the monitors. It's not like, it didn't detect it on either. So it was the same in both. The implantable device here, as well as the external monitor. And the mean time detection was 13 days. So one patient went home, and the next day you had AFib, and then to 26 days. So just showing you could pick up a lot of these patients that have cryptogenic stroke pretty quickly, even if they don't come in the hospital with AFib. And so, we did this preliminary cost analysis, which is just really the tip of the iceberg, just looking at the cost within the first month. Obviously, the implantable loop is more expensive. So raising the question, I'm trying to think of maybe the guideline committee was thinking, along these lines, without a lot of data out there comparing the two, but that you can save, a lot of money if you just put a monitor, external monitor on for a month, and then the rest of them, the other 85% put the loop in. Now, logistically, is that reasonable? I don't know. Our center, our stroke people come from all over, and they're not going to come back in a month. They're in rehab, So we didn't change our practice based on this tiny little, study. I think you need a larger study to, try to show that, logistically it works also. And then to get it even further, so those are super high risk patients that you're looking at cryptogenic stroke. What about other groups and just kind of screening? Now we're starting to get into the screening. So you have these patients that have devices for other reasons. They probably have, a lot of them have heart disease because some of them are ICD patients, pacemaker patients. Some of those may have heart disease. Then you get to the cryptogenic stroke, population, and now you have just high risk patients. When you get older, your chance of getting AFib, we know, goes up. So this is just looking at anyone. They used, when it was done, was a CHADS-2 score. And they might have even had some of these other risk factors for AFib, like renal disease or sleep apnea in many cases. And actually, this is a little bit of this was presented as a late breaker at HRS a couple of years ago. But a lot of these patients had symptoms. So it's not truly a screening the way I see it. Screening is screening people who don't have symptoms, but about 90% actually had symptoms. So I don't think you could extrapolate that to all the patients out there in the world who have risk factors, and again, it's an expensive device to put in everyone. But looked at the implantable monitor and looked for a mean follow-up here was 22 months. And you could see that overall, it was a very high likelihood of detecting AFib. 29% of patients had AFib detected in this group. And the median time from device insertion to the first episode was 123 days. And in 10%, episodes lasted 24 hours or more. So it would be something we'd consider potentially significant subclinical AFib that might require anticoagulation. So that's the beginning of the screening. Now, I don't need to tell everyone in the room, we have devices. We have the Alive core or cardio devices that patients come in, to my office all the time with different devices, and they can save their strip, and sometimes they're beautiful strips, right? You could see, AFib, and, yeah, they have it, and maybe they were having symptoms, and that's why they recorded it. Or now with these wearable devices, that they're wearing all the time on a watch is even more so. We're going to be seeing, we think there's a lot of AFib now. We're going to be detecting a lot more AFib, so it's crucially important to know what to do with it. And again, anticoagulation is just the issue we talked about today, but think of the other things. You could see people, getting lots of procedures and tests and stuff done. So we need to kind of know at least how to manage, some of that data when we get it. So the Apple Heart study, and I'm on the steering committee as a disclosure for this particular study, is looking at the Apple Heart Watch. Now, this study was done before the availability of that EKG monitor. We didn't, have that available at that time. It's looked, and what they were doing is testing irregular rhythms, looking for that by just using the pulse on the, on the wrist. And it's these tachograms using this, PPG measurement here, and just in looking for irregularity. So the primary outcome was AFib of greater than 30 second duration. Now, the amazing thing with Apple and all these other, big companies out there is the number of patients. I mean, we look to enroll, if we enroll 10 patients in a multi-center trial, we think we're doing great, sometimes. But 500,000 participants, and I can tell you, like, as soon as they send out an email or some kind of messaging, it's like you get this big spike, and I think actually this paper had the graph. It's like all of a sudden all these people enroll. I didn't participate too. I don't have AFib, but it's just amazing that the amount of data that's out there in the world now, right? So it started here, and it's closed. And actually, January 31st, the database was closed. And Mintu Tarakia, who runs this study, as well as Dr. Perez, are going to present that at a late breaker at ACC. So I actually don't. We have a call this month actually now. So I don't know the data and the results yet, but. And it's also comparing it to a patch monitor, so you can have some validation, not at the same time necessarily, because you detect the AFib. They have this whole remote system of healthcare providers that, it says, you go see your doctor, all this kind of stuff. But anyway, so we'll see what the results of that study are soon. So in conclusion, atrial tachyarrhythmias are common in patients who have implanted devices. Subclinical atrial tachyarrhythmias increase risk for thromboembolic events, although the risk appears to be lower than that for clinical AFib. Studies have correlated thromboembolic risk with the duration or burden of device-detected atrial arrhythmias, with an increased risk if it's over 24 hours. So I anticoagulate everyone who's over 24 hours, whether it's subclinical or not. It's just subclinical included. While AFib can be identified after cryptogenic stroke by prolonged monitoring, it's not a good temporal relationship between, and there's several studies that looked at this, between the subclinical AFib and stroke, which, means that we're just not detecting stroke from a plaque in the aorta, or it is maybe something else in the atria that's causing it if you have, severe, fibrosis or something in the atrium. So, in the future, we can identify the subclinical AFib. It's still unclear whether the very short duration ones of less than 24 hours should be treated with oral anticoagulation, and that the studies are underway to really determine what the appropriate duration that requires anticoagulation might be, so we know what to do with all these other people now when they eventually come in with their, wearable devices and ask what to do. So that's all I have. Thanks. Happy to take questions. Or?
Thank you very much for this great overview. Take any questions.
Yes.
The whole Apple and Cardia thing has really changed our practice. But the thing that's always frustrated me, and I wanted your opinion, is why Apple, for example, chose to offer medical advice in their application, in that I think they create a lot of panic for the patients because they say, we've detected an irregular heart rhythm, notify your doctor immediately. What did you all in your meetings have an opinion on that?
No,
Is it right
so,
or wrong?
yeah, no, so that, I agree with you, that it does create, some alarm potentially. Now, for the study was a different thing, that was because people are actively participating in a study. But, Apple, it's a funny thing, and I don't claim to have the insider information as, Mintu has really worked directly with Apple, they do come to these, these meetings. But it's a different world. I mean, even just, talking to them, they don't want to, like, they would want to get all this stuff out there even before there's, they just think we have to give information to everyone. It's a different way of thinking. Like, we're saying we need data, we need to show this works, we're pushing for more proof of this or that. Why they worded it that way, I'm not sure. I mean, I don't know if Mintu, decided that or not. But actually, even when the study was going on, we didn't even know that there was going to be an EKG monitor shortly thereafter. Like, they don't share. It's not like a two-way kind of street there. I mean, they have their own thoughts, and I think they did a good thing with the EKG is a nice thing. So, but I agree, and it does have, and it always raises this question with remote health, and so it's not like, so Apple go to see your doctor is the clinically available, but in the study they had like this contact, and I forget WellPoint. It was one of these companies that delivers mobile medical care. Apparently there are a lot of them, but you can talk to someone on the phone and they kind of steer you, not to a particular doctor or anything, but there's medical people that do this to try to get, do I think we're going to be out of business? No, but it's going to be to get people help for something that could be serious. So to answer your question, I don't know why, it's worded that way. I think they were afraid to see, they didn't know, like, in fact, I still don't know until we see the data of how good the algorithm tests for AFib clinically. When you see, because we won't even have, we'll have those little, rates, but, if you have something really irregular, that's different than maybe patients would go to the hospital, go to their doctor and get an EKG. But you're right, I think patients could be alarmed by that, especially when they're outside of a study. In a study, you make this active decision to participate. But it's a good point. We don't want to alarm the general public all the time.
Other questions?
So what about withdrawing anticoagulation therapy? So I've had several patients who we have, several sort of 1-hour runs of AFib, and we put them on a anticoagulant, and they have their device in, and a year later they've had months and months of no AFib or just a few beats now and then. I don't know what to do with those people.
I think that is a really great question. So, for, if patients have, so say first of all, if they have clinical AFib and then they don't have anything in their device, the recommendation would be to still continue it. So if they have over 24 hours or they've had an EKG with AFib, but I agree, they have this device in, could we do, some intermittent anticoagulation? So right now the guidelines would say you continue that patient lifelong unless they have their appendage closed with a appendage occlusion device, which is also now in the updated, focused updated guidelines. So it would be lifelong anticoagulation. If you have, the risk factors, DS-VASc of 2 or more in a man and 3 or more in a woman, you would be lifelong anticoagulation. So those stay on. Now, for the people who were in the gray area to begin with, and I could think of several patients that I follow, and who, actually one patient I put on anticoagulation was one of those kind of artesia patients. Of course, he literally tripped, and had this major, bleeding in his arm, and he hasn't had another episode. I never put him back on it, but he hasn't had another episode anyway after that initial episode that was a couple hours long. So the subclinical patients, I don't know the indication for sure up front. And then if they don't have any, but if they do have clinical AFib or they have AFib of over 24 hours duration, I would keep them on it unless they have some other appendage closure device. And then, then the question, comes up, and I don't know how you all feel, but after ablation, people feel, they're not having anything, and now it's a year or 2 years, or, they don't often have a device in, or sometimes they'll have an implantable loop monitor in, for a couple of years. Some people do that more routinely. And then what happens after that? And then could your first episode of AFib, be the one you have a stroke? So I usually anticoagulate those people as per DS-VASc score risk factor. I don't know if you guys do something different.
Same.
And actually Cabana, which was presented, well, the paper should be coming out soon on that one. The recommendation was to anticoagulate based on DS-VASc score, So not to stop it if you otherwise have a clear indication, regardless of the results of ablation. Same thing with antiarrhythmic drugs. Even though you see them in sinus rhythm, still the recommendation is to anticoagulate, because you can have recurrences, and we don't have data to say that you can stop it.
I have a question. So you discussed the duration of the duration of the episode, and we know there are data for 6 minutes, 6 hours, 24 hours. Do you think, this duration depends on the patient profile? For example, patients you put a loop monitor for cryptogenic stroke is different than a patient who have a dual chamber pacemaker, never had AFib, or a patient, for example, 40-year-old have an Apple Watch. I would think for cryptogenic stroke, maybe the threshold should be lower.
I agree with you totally. So I think that, I don't know for sure, but I bet you Jeff Healy comes up with some kind of, table. There was one published, but it wasn't based on a lot of data, so I didn't show it to you. But where you have DS-VASc score, on one of the, little, and then you have risk, you have, other things could be, the duration you can have, and if you have a duration of, maybe if I'm making this up, but if you have a duration of 12 hours to 24 and you have a DS-VASc score of 5, those people benefit. I don't know how much powered it's going to be to look at the specific subgroups, but yeah, I do. If they have cryptogenic stroke, I have a hard time not anticoagulating them if I see it. Yeah, I mean, I that's why I put the monitor in to see that. Yeah, but I agree. And it might only be, so then you say, well, it's only 10 minutes of AFib. But, it's kind of weighing those risks and benefits, and stroke is, I think, like the worst thing, I think.
Yeah, to piggyback on the question, so when you get these referrals for loop recorders, do you participate in recommendation for anticoagulation? For example, you see, because when you're reading the report and say you see 30 seconds of AFib, when you give the results to the neurologist, do you participate in recommendation or not?
Yes, that's good. So I guess it depends on how, and again, I don't know how your system, the patients that we're following their remotes, we do follow those patients, and we might only see them once a year. So we could still say we're connected to their care, but I would call like their outside referring doctor, and tell them, hey, we saw some AFib. If I don't really follow them that often, or just call the patient directly. I don't know if that was your question. Do you make a recommendation on, because if I've never seen that patient, so if I were following a monitor, and we don't do that, but if I were following a monitored patient and I never saw that patient, it would be hard for me without seeing that patient to give them something that could be, cause them to bleed or potentially adverse effects of anticoagulation. So I would either want to see that patient if they want me to see them, or for us, it's not an issue. Is that what was your question? Or? Yeah, but that's a good point, because it's like reading EKGs, right, sometimes. Oh, this is VTAC. It's like you're going to call the floor and, something, or they didn't recognize it, or, something, but you try to make that kind of contact.
How do you deal with people who have AFib in the setting of critical illness, and then you see them in follow-up and they've had no recurrence and they don't have any symptoms?
Yeah, that's the hard. You had to ask that. I actually don't know what to deal with that, and we see, so you see it after cardiac surgery, right? And you've never seen it before. Is it because you've never seen it before? Just never. You kind of. I look at this is not guideline driven per se. If you could really say it's clearly related to an acute illness, and sometimes if you're in the chest and you're rubbing against, you have a pericarditis, that's a good explanation. But if it's a surgery, like they had, an ACL repair or something, something like that, I got to think that patient's going to have more AFib. So I would do some additional monitoring. I would definitely do some additional monitoring as an outpatient. They might even be, some of these patients get put on short-term anticoagulation, and then what to do afterwards. So I don't think we have a clear answer to that question. I do have to say that many patients may have AFib down the line. And then there's certain things I'll look and say, oh, how big is their left atrium? If they have, a 5-centimeter atrium, chances are they're probably having it and I just didn't know it, or they're going to have it. But, if they have multiple risk factors, I would lean more towards that. But if it's clearly just an acute illness and their electrolytes are off and they're, you know, their blood pressure dropped, they got some pressors, or they really had a super acute thing, I don't long-term anticoagulate those patients. Yeah, but that's a hard one. But I do monitor. I do some monitoring on those patients.
Thank you very much.
Thank you.
The preceding program is copyrighted by Emory University.